Hello, and welcome to the UF Health Wellness University. Today's topic is Diabetes and Your Feet 101. My name is Marcia, and I'm your host. I want to go over a few things before we get started today. First of all, you can ask questions using the chat feature at the bottom of your screen. You can type a question in there, and we'll be happy to take those questions at the end. You can type your question at any time and submit it, but we're not going to answer any questions until we get towards the end of things. When I receive your question, I'm the only person that's going to see your question. So the whole audience won't see your question, but they'll be able to hear the answer if it's a question that's for the entire audience. So it's really pretty anonymous. Anybody can submit the questions, and only I will know who submitted the questions. At the end of the presentation today, you're going to receive a survey that's going to pop up on your screen. I'd love for you to tell us what you thought about things today, or provide us any feedback, or let us know how we could do things a little bit better. I'll share that feedback with our speaker as well. So I'd like to go ahead and get started. I'd like to welcome Dr. Leaha Neville from the UF Health Orthopaedic and Sports Medicine Institute. Dr. Neville is a UF Health podiatrist, and she's board certified in foot and ankle surgery by the American Board of Foot and Ankle Surgeons, and she's a fellow of the American College of Foot and Ankle Surgeons. In addition, she's a board certified wound specialist and fellow in the College of Certified Wound Specialists. Thank you so much today for taking the time to do this presentation. I'm going to go ahead and turn it over to you, Dr. Neville. Thank you.
Hello, everybody. I'm sorry we can't meet in person today. I hope everybody is at home being safe, given the pandemic with COVID. I really hope to talk and try to answer some of your questions about diabetic feet problems that you may have. You may have a loved one, a family member, a friend who's suffered some problems because of diabetes complication to the foot. So we're going to go over that. Let me get my slides up for you. I apologize for that. So today we're going to talk about diabetes in your feet and how to keep them healthy. I have no disclosures to talk about or to declare. So diabetes is really an epidemic. It's affected everybody worldwide, and especially here in America, we have over 30 million people with some form of diabetes. In the future, we predict upwards to 84 million people have some risk factors making them at risk for developing type 2 diabetes. And a lot of times you hear about type 1 and type 2 diabetes. Type 1 is often something that you may find people at a younger age get, and really related to autoimmune concerns. Type 2, we find people can have family histories related to having more of a predilection of getting diabetes, possibly weight gain, heart disease. Things can play roles into higher risk factors. We also know that it's not just something that affects us in America, but worldwide. We talk about the pandemic right now with COVID. Well, diabetes is really an epidemic. We see that upwards 55% increase worldwide, and upwards to 592 million people will be affected by some form of diabetes by 2035. Not only can it be devastating for somebody that has to deal with the complications of diabetes, but we also know it can be very costly, not only for a person that may affect their ability to work, but also for healthcare costs. Believe it or not, upwards to $327 billion in 2017 were related to care for diabetics. So not only do we want to educate our patients so they know what and how to take better care of themselves, but that we want to work together as a team so that we have good quality of life and we can prevent some of these complications. We know that diabetic neuropathy is one of the leading causes of debility. Most of the common causes or concerns are developing a diabetic foot ulcer, and unfortunately, sometimes those succumb to a lower extremity amputation. So why do diabetics have so many problems with their feet? Well, we know that diabetes can affect the circulation, the nerves. Some people, their whole lives have had to have bunions, hammer toes. Maybe they had a fracture that took a wider heal because they were diabetic. Wound healing or bone healing can take longer. Possibly developed an infection. We know that diabetes can affect your ability to fight infection, no different than the news stories every day relating to diabetes. With COVID, we want to keep everybody safe and healthy. Things to think about as we go through this talk today. You know, do you have numbness in your feet? Have you lost some of your sensation? And not everything is due to diabetes. Sometimes people have back problems that impair the nerves that go to their feet, or on certain medications, like they've had chemotherapy. We also know that poor circulation can be a causative effect, causing changes in the skin in the feet or your ability to walk comfortably. Do you have a callus that keeps coming back, or has this possibly turned into a diabetic foot ulceration? You may know somebody, a friend, a neighbor, who's had a wound and it took quite some time to heal. What kinds of shoes do you wear? You know, for shoes, it's like building a good house around where you live. Your shoes can do that. It can be very protective. Shoes can also be problematic. Do you have bunions, hammer toes? Have they gotten worse? And maybe over those areas, not only does it cause joint pain, but it can cause pressure or skin breakdown. When you look at the schematic, you can see all of it is interrelated. And we're going to talk about them individually today and try to bring that all together to give you some information to take home. So risk factors with diabetes, especially in the lower extremity. We know, unfortunately, when we gain weight, sometimes it's hard to lose it. A lot of us are at home right now. Our lives have been disrupted. We haven't maybe been able to exercise or eat as normally as we did. We're doing our best. We understand that with increased or poor control of your diabetes, we know that the risk factors go up. So the doctor may talk to you about, is your diabetes controlled? What was your blood glucose? And it's not so much to pick on you, it's to sort of start the conversation of, do we have to do something different, or what you're doing to take care of your diabetes is successful. People that have high blood pressure or high cholesterol often may also have heart disease. We understand that diabetes and heart disease, when you put that combination together, sometimes also can be increased risk factors. So keeping those both under control, really important. People that smoke sometimes, unfortunately, can have increased risk factors like circulation issues, or maybe family history. You may have multiple family members who have diabetes and you've seen their struggles or their successes. Sedentary lifestyle, you know, if our feet hurt, it's hard to get out there and exercise, and hopefully we can give you some help for that today. Do you have a foot problem that's actually keeping you being able to exercise or to walk comfortably? Some of those need to be addressed in order to let you have a better quality of life. So I'm going to keep it real simple. We're going to talk about the ABCs. What's the ABCs? Well, a lot of times when I meet my patients, one of the things I might ask them is, what's their A1C? I might look in their chart. Fortunately, at UF, we have a wonderful charting system that we can a lot of times share the data and try to learn more about our patients. An A1C is sort of like a batting average. You may check your glucose on a regular basis, or how your doctor has instructed you to do that. Well, that's sort of like a look back. On average, what has your A1C been for maybe the last 3 or 6 months? That number tells me a lot about maybe how is your diabetic control? Is it good? Is it bad? Often it can be a number between maybe 6 and 7. Sometimes I'll meet patients that unfortunately are having a hard time controlling their diabetes. It may be in the 8s and 9s or even higher, 11s, 14s. Believe me, I've seen it all. That number is super important. It may be a goal that you set to get that better controlled, or you've already accomplished your goals and you want to keep it there. I do find that your A1C often gives me insight that if they are running high, if it's not well controlled, often I'll see these people that possibly have more complications, and we want to do our best to eliminate or prevent those. Blood pressure, cholesterol, those are things we're looking at to make sure, you know, with the blood pressure being high, it can affect your kidneys, it can affect your eyesight, and so can diabetes. Technology keeps getting better and better. The pictures on your right show a person that has what we call a CGM. Well, what's that mean? Continuous glucose monitor. This is a thing that is put on their body in a special area, and they can check their sugar without poking their finger. I really hope in the future, more and more people have the ability to use such a thing. Finger sticks. That's something that you may be very familiar with and you do on a regular basis to check your sugar. So we're going to go through some things like talking about circulation and then nerves and then skin. We're going to start with circulation. I think that's one of the most important things. I meet many people every day, and the biggest thing I'd say is I hope they have good circulation. If they don't, it can definitely impair their ability to walk comfortably. It can cause pain, swelling, discoloration. We also know if they have a wound with poor circulation, it may be very difficult to heal. And we want to identify that early on and get the right treatment. With diabetes, we understand, and these might be difficult terms, but I try to spell it out. We have increased inflammatory processes, not only in the heart. You might know somebody who has coronary arterial disease. Well, those are the arteries that run through the heart. Well, the arteries that run from your top of your leg down to your toes can get blocked as well. Sometimes they get blocked and it causes pain when you walk in your calves or in your thighs. That's called intermittent claudication. Now that might be something difficult to always figure out because people get arthritis that can cause pain when they walk too. But it may be something, if you have that on your mind, to bring up to your medical provider to see if it's a concern that should be looked at. We also understand that diabetes have more of a risk factor for getting clots. They may have increased swelling in their legs or discoloration, maybe rash or blister that comes and goes, especially if your legs are hanging down. Possibly a person develops a wound on the bottom of their foot. And looking at the pictures on your right, you can see this is a clear blood vessel. Hopefully you can see my cursor. And this is a vessel that has blockages. So you could see where the blood getting down to your toes may be blocked. The next picture shows a foot that's pretty normal color. They have some swelling. The other foot has some significant discoloration. We sometimes call that rhubarb. This person has poor circulation going to their toes as well as getting back up to their heart and definitely needs some special evaluation and treatment. When we get down to the bottom of the toes, we know the blood has to go back up, and it does it through veins. As we get older, I know we get veins that are very prominent or discolored. Those veins can also get clots, and the swelling can cause problems even putting on your shoes. Also, the last picture shows a sore on the bottom of your foot. And there's many people that have a hard time seeing the bottom of the foot. Maybe they have arthritis in their back or difficulty bending, or maybe poor eyesight. But that small wound can cause a lot of problems if it gets infected or goes to the bone. So those are things that checking your feet. So when a person has peripheral vascular disease, there's special tests that we can do. We want to identify them, possibly send them to a vascular specialist. Down below, we see that we're looking at, is there any blockages? This person is holding a probe, and this is actually a very comfortable test that they can look if you have appropriate circulation going to your foot. If there's impairment, we may send you for a test that you see below. It almost looks like a heartbeat. That's showing that this person has good pressure in their leg, but as it goes down to their toe, it almost becomes a flat line. The picture to your far right shows an angiogram. That's a very special test where they put dye through your body to identify the blockage. With doing that, you see there's a cutoff. Well, that person may need to have a special procedure, maybe a bypass or an angioplasty to open that back up. When that's done, that helps to reestablish circulation to their foot. Moving from arteries and veins or circulation issues, we're moving now to nerve issues. And I know that can be sometimes confusing. I have many people that come in that say, you know what, my feet are numb, I must have a circulation problem. Well, actually, I'm gonna say it might be actually a nerve problem. Peripheral neuropathy is very prominent in many patients that have diabetes. Upwards to 60 to 70% may have some form. And it's not always pain. Sometimes it's numbness, burning, tingling. If you talk to 20 different people, they may describe it in very different ways. And that's because they get it in different ways. It's both a metabolic and a structural problem. Well, what does that mean? Inside the nerve, it may have impairment. If you think about the cable line that comes from outside your house and delivers your internet or your phone line, that delivers information from your brain down to your toes. It may tell you if you're hot, cold, if you feel something sharp underneath your foot. Well, as a diabetic, when their nerves are damaged, that becomes much dampened information and hard to distinguish. It also can affect the muscles, your ability to sweat. It can even cause skin changes. We also know it can affect your balance, increasing the risk of falls. Looking at the nerves on the top, this is a normal nerve that has good insulation on it. The nerve on the left, the insulation has worn out. With high sugar levels, we find this happens at a much more accelerated rate. You may go to the doctor and use a small probe to check your sensation or do other tests. When you look at this foot, it looks really skinny. Well, believe it or not, we find that diabetes and the nerves will change the muscles, the skin, and it will often, over time, get more noticeable. So we were mentioning a minute ago about your ability to walk. Well, not only diabetes, but as we get older, you know, how we walked at 18, at 40, and at 80 changes. You know, our joints might get stiff because of arthritis. We may have a hard time deciphering uneven ground or stepping off a curb, walking out of a store. The downside is when you get afraid to walk because of your neuropathy, a lot of people stop walking, whether it's for daily life or exercise. So again, keeping that diabetic sugar under control, talking to your doctor about, hey, I'm really having a problem. I'm struggling with being able to do stuff. We often find people may not be able to pick up their feet easily or accidentally trip because of weakness in their lower extremity. We may find they shuffle or lean forward or grab onto the counter, the car in the parking lot. I often tell my patients, do the grocery cart test for me. If you go to the grocery store, they'll say, gosh, getting from the parking lot into the store is so difficult. I can't wait to get onto the cart. Once I get on the cart and I hold on to it, I can go up and down those aisles with no problems at all. Well, that makes sense. That grocery cart is almost like a walker. It grounds you to the ground. It gives you security, safety. I know some people really say, you know, I don't want to use a walker. It makes me feel old. Or I'm really young, but I have neuropathy. Can I go without it? Well, a lot of times they say, well, why don't you try? You may have a better day by using something like a walker, a walking stick, a cane, and it doesn't have to be all the time. If you're really struggling with your balance, you may talk to your doctor or your medical provider about going to physical therapy. I send many patients for balance therapy. It can be really helpful, not only for flexibility, strengthening, but building up your confidence, especially if you suffered a fall. With neuropathy, we also see people suffer with pain. I wish I had a magic wand to take it away. Unfortunately, neuropathy, because of diabetes, is very hard to reverse. So trying to prevent it is one of our goals. Keeping that diabetic control good is so important. I'll tell you a quick story. I saw a patient yesterday who had had diabetes for 35 years. She was on dialysis, but she had such good control. That A1C we talked about was in the 6 range. When I checked her feet, she had very good sensation. So even though she had had diabetes for over 35 years, she had done a great job. Later that day, I saw a gentleman whose diabetic control was in the 9s. He'd only had diabetes for 5 years, and he was having tremendous amount of problems walking, even a block. For this gentleman, I thought, let's get him a circulation test. He needed to get his diabetic control improved, working with his medical doctor. And we had a hard discussion about if this keeps this way, it may really affect his quality of life in the future. Well, the pain is real, and we try to help with reducing pain. Sometimes topical medications, even over the counter, can be very therapeutic. It doesn't always reverse it, but can make you possibly be more comfortable when you sleep at night. Many people will say, hey, I have only nerve pain at night. Well, sometimes it's because you turn off the lights and you're not really paying attention to all the craziness during the day, and you notice those nerves seem to be acting up. Supplements that you may want to talk to your doctor about, like vitamin B, can be healthy for making your nerves more strong. Sometimes oral medications, and people listening to this, talk today may be on gabapentin, Neurontin, pregabapentin, amitriptyline. There's many medications that can help decrease the amount of pain. At the same time, we want to be careful with that because there can be side effects, and that's something to definitely talk to your medical doctor about. Often, if the pain gets to be really concerning, possibly seeing a specialist to help with pain management. So moving again from nerves, now we're going to jump into skin. Diabetes definitely affects the skin. You may look at your skin and say, gosh, it's so hard, it's so dry. Well, believe it or not, the nerves, as well as aging process, can play a role. We may find we lose the cushion on the bottom of our foot. We may find that it feels like we're walking on a bag of bones. Often, what you put on the bottom of your foot, like a special shoe or a sandal, can be so helpful for this. Looking at these pictures, we can see how the cushion goes away and it flattens out. We may not have as much hair growing on our legs as we once did. They may have discolored, or even just bumping it, you get a small skin tear or a scratch that may take longer to heal. People will often get calluses on the bottom of your foot, and some calluses can be, for the most part, normal. We have a lot of people that barefoot walk, so again, that's going to make your skin a little bit harder against the hard ground or concrete or wood floors. We may see people that have discoloration in their legs, and that can be due to sun damage. It can be due to circulation problems. If you're having a problem with that, it may be worth a discussion with your podiatrist, your dermatologist, or your medical professional. If you think about skin, skin's a barrier, like a wall. We want to keep the bacteria out. When you do have an opening, it makes it an easy doorway for infection to get in. So taking care of that, you may find that a wound on your foot or leg takes a lot longer to heal. We'll often see with diabetes, the higher the less the control, it may take longer, but that could also be, age. We don't want to blame everything on diabetes. It could be circulation, or maybe we need to have wound care to help with this process. Your skin may be itchy and dry. Using moisturizers or an antifungal. People may struggle with ingrown toenails where the nail gets hard and thick. And seeking out the podiatrist to have care provide for that is definitely reasonable and recommended. The bottom pictures, often when a person comes in, if they tell me, gosh, doc, I had an infection, I will often start at their toes and work all the way up, looking, do they have any cracks in their skin, any peeling? Because these are all areas that infection can get in. And we want to take care of that by controlling maybe the moisture, making sure after showers we dry real well between our toes, or using special medicines, even topically, to help this process. I know it's hard. Not everybody can get down to their toes easy, but possibly having a loved one, a caregiver, check your feet. I really recommend, if you can, getting into your daily care of your feet. It's one of those things like brushing your teeth at night. If you can take a couple minutes to inspect your feet, moisturize them. It's funny, a lot of people will put moisturizer on their leg. They always stop at their ankle. I said, no, put some on the top of the foot, on the bottom, as long as it's not going to make it slippery. I often encourage you not to put moisturizer between your toes. That area is almost moist enough, sort of like our armpits. Antifungal creams, powders can be very helpful, especially living in Florida where it's super hot right now. People often ask me, hey doc, can I soak my foot? Well, that's a question that really is difficult to answer. Sometimes it's hard in the shower to bend over and wash your feet. So maybe doing a little Epsom salts or warm soapy bath would be totally appropriate. I do encourage people who have a sore on the bottom of the foot or somewhere on their foot not to soak their foot unless their medical provider has told you that's part of the treatment plan. Sometimes that can cause maceration or breakdown of the wound. And again, if you're having a wound that's not healing, probably the best thing to do is make an appointment with your doctor and have that checked out. Barefoot walking. I often encourage my diabetic patients not to barefoot walk. It's a hard habit to break. Many of us grew up running around barefooted. Unfortunately, if you don't feel your feet, sometimes you can step on something, whether it's glass, a thorn outside, a nail, or get bit by an ant, a spider, which can cause problems, redness, infection. Unfortunately, if you don't always feel everything in your foot, you may not even realize what happens. Often a patient will come in and we're trying to go through the past medical history to figure out, where did this come from? How long it's been there? Callus care, whether it's a callus cream to help moisturize the skin, the right shoe, or you're going to your podiatrist to have those trimmed if you have at-risk factors, are definitely appropriate. So moving from having just a simple callus to so many people here or know somebody, or maybe you yourself have had a diabetic foot ulceration. And it can be pretty scary. But if you catch it early and treat it, it can be a good outcome. And that's really what our goal is. These pictures may be a little bit graphic, and I'm not showing them to gross anybody out, but I want you to be informed. I think the more you know, the more you can figure out what's right for you. Do I have a problem? Do I need to see a medical professional to have this checked? Well, why do diabetics get neuropathy and then get ulcerations? Well, with numbness in their feet, you don't always feel that pressure. We also know with the circulation, that area may be weaker. Over time, you may feel and build up a callus. This person even has a small amount of blood because of the pressure. As that callus gets thicker and thicker, it gets black and blue. And believe it or not, underneath there is an ulcer hiding. Now you may say, well, there's no drainage and no redness, and that's a good thing. But underneath there, there's actually an ulcer. With repetitive trauma and irritation, as you walk, it becomes more and more of a problem. With doing that, it can break open and become a sore. And that's what you're seeing in this third picture as we go down these steps. With continued breakdown, this wound can get deeper and deeper. And in this person's foot, it's actually all the way down to bone. We know with continued tissue destruction, we are at higher risk of infection, and this would take longer to heal. So again, if we can catch this early, that's a good thing. Diabetic foot ulcers on average for some people can take 6 months to 1 year. Hopefully, if you're listening to this talk today and you've had a diabetic ulcer, it didn't take you that long and you were able to successfully heal it. But we also know that 70 to 100% of people who've had an ulceration are at risk for getting it again. So if you wore that shoe that caused that sore, do me a favor, get rid of it. Don't go back and wear it, because chances are that shoe will probably cause the same sore, and then the whole cycle starts all over again. When my patients heal their wound, I get so excited. I tell them I'm going to go do cartwheels in the hallway. But I also tell them we're not out of the woods yet. Once they heal their wound, I often encourage them to keep it covered for a couple weeks, changing the dressing, keep their eyes on it. Maybe if they wear a sock, check the sock, make sure they don't see anything like blood or discharge on it, because that wound has to get stronger. The skin has to build up. And especially after you heal it, at least 4 weeks, it needs to get stronger to keep it from breaking back open. We definitely understand diabetic foot ulcerations definitely and significantly impact patients' life, as well as their ability to go around, their mobility, their livelihood, their ability to perform their jobs. Believe it or not, there's a 5-year mortality rate of 45% of people who get diabetic ulcers. And we want to do everything in our power to keep our patients healthy, safe, and proactive. So often when I meet a patient who has a diabetic ulcer, I may ask them lots of questions. I want to know, how long has it been there? Where did it come from? They may not be able to tell me the whole story because they didn't feel it or when it started. On this person, they have a hammer toe, they're getting a sore. This can easily go to bone very quickly. Possibly the shoe they wore rubbed a sore, it gets red, drainage, heat. A small little wound like this can cause big problems. So we don't even want to underestimate a small wound is not a problem. A wound with a diabetic patient, we want to take good care of that. I want to know, how is their diabetic control? And I know I sound like a broken record, but it plays a big role. We know that people that are not well controlled will have a lot harder time healing it because their body has to work harder to fight any infection. I want to know what kind of shoes. I have them bring in their shoes. We try them on, we check them. The next thing is when we start to think about treatment, I want to know, do they have a history of fall? Because I might want to put them in a special shoe that makes it harder to walk. Well, I don't want to create a problem, but we have to do special things to get this healed. Also, do they have other problems going on? Maybe they're going through cancer treatment. Maybe they're on dialysis. Maybe if I'm going to put them on an antibiotic, I need to know how their kidneys are so we don't impair those. Also, I want to know, is there somebody at home to help them change that dressing? Believe it or not, putting on a toe bandage is not always easy. I've been doing it for about 21 years. The more practice you do, the better you get. And if the person can't reach their feet, well, then we need to get them maybe a home care nurse to come to help, or maybe recruit a family member to stop in and check their feet for them. Treatment of a diabetic ulcer is not a one and done. It takes multiple treatment plan that we're going to do all at the same time. Basically, we may start with wound care or debridement of the ulcer. Debridement is often when we're trimming on the wound. Some people turn to me and say, well, aren't you going to make it bigger? No, we're going to remove the bad stuff so the good stuff left behind can heal. Offloading the pressure area, whether it's a special device. This picture here is what we call a total contact cast. It's a very special device that we put some of our patients in who have diabetic ulcers. As the ulcer gets better, we may move them to a diabetic shoe, and people that have risk factors, fortunately with Medicare, often can qualify for a diabetic shoe with a special insert. That's one of the ways we may work to prevent that sore from coming back. I may ask my patient all about what they eat on a daily basis. How is their glycemic control? Because believe it or not, the longer we do wound care, not only does it matter what we put on the wound, but it also matters what we put in our mouth. If you're a pop drinker, I try to get you to drink your water instead of maybe so much sugary pop. If you don't eat much protein, maybe eating some chicken or beans or broccoli will help with wound healing. So those are all things that we really try to look at the whole person, not just the foot. And as we already reviewed, we check their circulation. If they don't have good circulation, we need to figure out what's the next step. When you look at this picture, there's a lot going on here. Basically, wound care is very comprehensive. We may be putting people on antibiotics, putting them on special dressings, and there's thousands of dressings these days, and we pick them very selectively. We may put them in a special device to take the pressure off, or ask them to decrease the amount of activity so we can get that to heal. We may need to have surgery or special products. This over here is actually a wound vac, and some of you listening today may know somebody or you yourself have had a wound vac. It's a special device that helps wound healing. This is a person here debriding a wound, and this is something I often do to help with wound healing. Now, I know this picture can be a little overwhelming, but we can't go without saying diabetic foot infections are very serious. It may be something where we need to send the patient to the hospital. This is not something to delay about. This is something that needs quick action and good care. This is a patient I had in the past who had a wound. It got very infected. When I saw him for the first time, we needed to hospitalize him. He, believe it or not, had gas gangrene and needed to undergo surgery. Cellulitis is an infection in soft tissue, but this person had already had infection that had gone down to the bone. We want to catch this early because we understand in the medical field, and patients need to understand the stairway to amputation. I don't show you this to scare you. I show you this because I really care and I want to inform you. Diabetes and diabetics often develop neuropathy. With that, your risk of ulceration goes up. And when you have an ulcer that is slow to heal, The longer it's open, the more risk for infection. Or when you have a new wound, you may not even know about it, and by the time you recognize it, there's an infection there. We also know it affects circulation, or the word ischemia. And why we talk and care so much is because we want to prevent amputation. We know that 20% of hospitalizations in America are because of diabetic foot ulcerations or infection. 15% of diabetic foot ulcerations can result in amputation. And again, we want to do everything we can to prevent. It can be very scary. Your doctors, your medical providers, your nurse practitioners, your wound specialists, all of these people are here to help you. It may not be an easy process, but it's one that can be successful. Sometimes, unfortunately, the definition of success does not always mean healing. It may mean amputation. I've taken care of patients who've had wounds for years. And sometimes the best thing they can consider, if it's right for them, my patients always make the ultimate decision. I will give them the best information, but it may require an amputation. You may look at this picture on your left. This was one of my beloved patients who had an amputation of his toes. This is called a transmetatarsal amputation. Believe it or not, after he had this amputation, this foot did great. His left foot, with the right shoe that you can see here, nobody even knew he had it if he was walking around with his shoe. The funny thing is, or maybe not so funny, his right foot was always causing trouble. His fallen arches, his hammer toes, it was not very strong, and we had to keep him in a special brace. So I sometimes tell my patients who've had to succumb to amputation, toes are overrated. We want to keep them, but there may be a reason that it's best to consider amputation. We know that 85% of lower extremity amputations started with a diabetic ulceration. The patient I showed you earlier with that bad infection, this is him about a month later. He was able to successfully heal, but did undergo amputation. He's back in his shoe, and he has a special device to act like his big toe. So I'm going to come to the end of the diabetic foot ulcers, and we're going to move to another topic called Charcot foot. It may be something you've never heard of. I just mentioned this because it's something that really impacts diabetics, especially those that have renal disease or are poorly controlled, and hopefully that will get better with treatment and time. Charcot can look a lot like an infection where all of a sudden the foot gets hot, swollen, inflamed. I see many people at the orthopedic department who have Charcot, and it can go from an age 30 all the way up to when you're in your older years. It's a condition where the foot becomes very angry and inflamed, and you develop fractures. There may or may not have been an injury. You may know somebody who's had this, and every time you see them in a special cast or boot, and you think, gosh, they've had that on forever. Believe it or not, this type of condition can take well over a year to go through treatment. Why I bring it up today is informing you that if you get pain and swelling and something doesn't feel right, or your foot's changing, it may be a simple, tendonitis, but it also could be a Charcot concern. And that would be something that your doctor can help you figure out. We find over time, looking at these X-rays, and hopefully you can see those well, this person has a normal foot, and over time develops multiple fractures, and the joints spread out and collapse. With time, a person with a normal arch gives way. In the picture in the middle, you can see, gosh, they lost their arch and their bones have really collapsed. This type of foot has a lot harder time working the way we know our foot to work. It may require a special brace. This is a crow boot, which is used specially for this condition. Later on, we may move them to a special brace. These people are at greater risk for getting wounds, and sometimes they require surgery. Other people who are diabetic may have bunions. It may be something you've had since you were a teenager, and over time it's gotten progressively worse. The two pictures on the top show a mild bunion and show a very severe bunion. So remember, when you get information, everybody has different ways of treating things and different severity of the condition. So it's not one size fits all. Many people will go to the internet and try to read about their condition. But I think also if you have concerns, making a list and talking to your medical provider about this. You can see somebody with diabetes that have neuropathy, why they can get a sore over this if they wear a shoe that rubs. But you can see this person is at much greater risk of getting a sore over this bony prominence or getting a sore over their toe on top. That's really a bony problem, so it's not a quick fix. It may be something of getting them a special shoe, or if they're an appropriate candidate, talking about surgery. We also know even with neuropathy, we can get other problems in our feet, like arthritis. This person has great toe arthritis, and when they walk, it hurts all the time. Or they may have a spur on top of their toe if you see the picture in the middle. Some people will get hammer toes, and you say, gosh, my foot keeps changing. My toes are getting more crooked. That can happen because of certain foot structures. It can also happen with your balance because your toes are trying to grab the ground. And you can see all the bones. There's actually 3 bones that are made up into the toe. Those are affected, and over time they change. So treatment course is very specific for different people, and we don't all fit into one mold. Some people just need some conservative treatment and can do quite well. Other people may require surgery, and each condition is very unique. Getting a treatment plan, maybe trying simple stuff. If the problem gets worse over time, it may be time to consider where this person down in the corner actually had bunion surgery and had a very good outcome. Just because you're diabetic does not mean you can or can't have surgery. Basically, all the things we've talked about earlier, your nerves, your arteries, your glycemic control factors into, is this the right thing for you to ultimately decide need to be done? We may find simple things like the right shoe. This picture here shows how the foot is crowded into a very tight shoe. I would much rather change the shoe than change the foot, and that may fix this person's problem. Common other problems that we see on a regular basis is pain in the heel, plantar fasciitis or heel spurs, stress fractures, tendonitis, or fallen arches. People that sometimes were born with flat feet, well, over time they get flatter. Sometimes that can make it very difficult to walk or even find shoes that are comfortable. So I find that initially, possibly needing to provide them treatment like a walking boot, a special shoe, or just recommending even an improved shoe can very much help with this problem. And we don't want to blame everything on diabetic neuropathy. Sometimes there's something else going on inside the foot, like heel pain, Achilles pain, and those are things that we treat every day to help not only people with diabetes, but people without diabetes. Some diabetics will have an accident, fall, or injury. They may fracture their foot or sprain their ankle. Those can be very serious. And you have to remember, you know, when you're a kid, maybe you hurt yourself and after a day or 2, it got better. If you noticed you hurt yourself now and you have neuropathy, sometimes you don't always appreciate the pain. If it's bruised and swollen and it's not improving within a day or 2, it may be worth getting checked out just to make sure you're not underestimating the injury. When we do treat diabetics with this type of problem, often I will need to immobilize them with special boots or splints. And you may think, gosh, it's taking a long time. Why is she keeping me in this for so long? Well, believe it or not, just like our skin may take a little bit longer to heal, so will our bone. And we really want to control the swelling. We want you to have the best outcome with healing that fracture so you don't get early arthritis or weakness in your foot. Lastly, shoes are so important. I find, again, it's a good house around your foot. If that shoe that you keep wearing is causing pain, sometimes just simply going to a more supportive shoe. These days, a lot of the shoes have become real soft. I have many people that spend their whole day and I say, gosh, you're not really wearing a shoe, you're wearing a slipper. Often I'll take their shoe and in the down corner, I'll try to flex it. Often I'll encourage the patient maybe changing from a super soft cushiony shoe, which people often like, to a more stiff shoe that if you bend the shoe, it doesn't bend as equally. Something that simple can often encourage pain relief, also make it easier to walk. Often, if you get swelling in your legs or have those bunions like we talked about, you may need a wider shoe. They don't always have to be expensive, but I encourage you to look, maybe this shoe, does it come in a wide? If you're trying to fit your shoe and nobody's there to help you at the shoe store, it may be worth checking out a shoe store that has somebody to fit you. If you have to do it yourself, I say reach into that shoe, pull out that inner sole, if they don't mind, and put it on the ground. If you put your foot on top of it, do your toes hang over? Would it be better to get a wider size? I have many patients that wear flip-flops. I really try to get them to wear a sandal that has a back strap or an adjustable strap. One, it lets you walk much more safely from your heels to your toes instead of sort of sliding along or shuffling. It's also adjustable, so if your feet tend to swell as the day goes on, you can adjust it. Everything we talked about today really requires a team approach, and the patient is the center of that team. We want to do the right thing for you, but if we don't know about it, please ask. We're here to help. You may see specialists like endocrinology, circulation or vascular doctors, our orthopedic doctors, someone like myself, a podiatrist, an orthotist to help make a brace, or physical therapist to help make you stronger. Take home points today to think about. Please don't try to remember everything we talked about. I don't want it to overwhelm you. It's just to inform you. But it may be worth asking your doctor, if you don't understand your diabetic control, to maybe attend a diabetic class or nutritional support with a dietitian. Proper diet and exercise is everything. So if you're struggling with that, again, talking to your medical provider to see if there's something we can do. Sometimes the internet or books can also help with that if you like to research it yourself. And if you have questions from that, don't be afraid to ask. Checking your feet daily, inspecting them is so important. And if you can't do it yourself, maybe a mirror on the wall, a friend, a loved one can help you. Shoes really matter. So if it's something that is rubbing a sore or you buy a new shoe, go through a break-in period. Wear it a little bit every day and make sure your foot likes it and that you like it. Because of diabetic neuropathy, remember, just because it doesn't hurt doesn't mean it's not broken. If something's changing, it may be worth getting it checked out. If you have a wound, don't ignore it. If it's not improving within several days, it may be worth making an appointment or even reaching out to your doctor to send them a picture through MyChart to get an opinion on, hey, should I come in for this or do a telemedicine visit, especially given everything we're going through now with COVID. Lastly, preventative care and early treatment often leads to better results. I want to thank you today. I hope this was informative, gives you things to think about, and maybe you can apply to your daily life or those that you know that have diabetes if you don't have it yourself, or things that you can prevent in the future. I'll send it back to you, Marcia.
Okay, thank you. That was a great presentation. I'm going to go ahead and take some of the questions now. And let's see. The first question we have is, could you maybe talk about the difference in foot complications for type 1 versus type 2 diabetes? Is there any difference with those?
Yes and no. I will say type 1, as people know, it's more of an autoimmune. So often they're affected at earlier states in their life. Often they may, as they get older, become what we call brittle diabetic, or may have more impact on circulation or neuropathy. I've met diabetics who are type 1 in their 70s or 80s who have amazing feeling in their feet and have really done well because they've practiced such good preventative care. I think as time goes on with insulin pumps and improved diabetic management to help these people, I find that they can heal. I sometimes find that they're actually better controlled because they've been doing it for so long and so well educated. But one concern I often will have is getting their circulation checked out. Type 2 diabetic patients may have had it for a very short period of time. They may have very good circulation, but if they really haven't embraced their treatment plan, their diabetic control may be very poor, and they may really struggle with trying to get that diabetic ulcer healed. Applying wound care principles pretty much is very standard and comprehensive. So when I'm looking at a wound, I'm thinking of all those things we talked about. I don't necessarily have to say, well, you're type 1, we're going to treat you this way or that way. But it may make me think, you know what, let's send this person for a circulation test to make sure that their circulation is good, knowing that they've had diabetes for a longer period of time.
Okay, thank you for that. We also have another question. What is the typical rate of rejuvenation? I've heard for approximately a 7 millimeter, it's going to take about a week. Is it the same for a diabetic?
Rejuvenation is, are they able to clarify that? I'm not sure if they're talking about rejuvenation for a wound or for a nerve.
For a wound.
Okay, so our goal is usually to try to get a diabetic foot wound to heal in 4 weeks. If it's not healed in 4 weeks, we often go to advanced wound care therapies, whether it's skin grafts, biologics, meaning special tissue grafts that we're not taking from the person themselves. We'd like to see about a 20% improvement weekly. So often you may be going to the doctor, the wound care specialist, myself, or whoever is managing your wound to have it measured and checked out. Now, sometimes if there's an infection that can delay healing, if they have to have improved circulation, that too. So really, our goal is 20% improvement. The 7 millimeter measurement they mentioned may be appropriate for them, but everybody's wound measures differently. So I'd say when you take that and apply it to how much improvement, we actually do that by surface area and measurements. That would be something to ask their doctor to think if they're in the good, if they're making good progress.
Okay, thank you. So I have another question. I'm interested in getting a glucose meter. Can I request that through my diabetic doctor, or is that an over-the-counter purchase?
From what I understand, and again, I'm going to refer back to my medical professionals like your internist, your family doctor, and your endocrinologist. But what I understand is that you do need a prescription. Now, these days with Amazon and some of these other places, you may be able to buy it over the counter, but often you need a prescription to get your test scripts. Or test strips. I often encourage you to check because a lot of these things are covered by your insurance plan. And I will say they've become a lot more affordable. So your doctor probably can point you in the right direction if they think you need to check your sugar and how frequently. And like we talked about, the continuous glucose monitor is a real game changer. Believe it or not, my husband is a diabetic. He has one, and it's amazing how much it has helped him get in good control.
Okay, good to know. Thank you. Another question. I'm a physical therapy assistant, and I had a patient that was supposed to have a toe removed after he was released. And I went for the next therapy session, and the amputation was above the knee. How common is it that the infection is going to get that bad, and how fast can the infection spread? He is seeing a doctor regularly.
It's a great question. And as a physical therapist or physical therapist assistant, you guys play a key role, especially for a person who has a wound. I often tell the specialist, like a therapist, tell them that you have a wound because sometimes you're not taking off the socks and shoes to check your foot. And that person that you describe, my suspicion is they had very advanced circulation problems. And sometimes the level of circulation problem, they cannot reestablish circulation to the foot or at the ankle. So unfortunately, they succumb for a below knee amputation.
Okay, if you get plantar fasciitis, is it a sign that you may be getting diabetes later in life?
Not at all. Plantar fasciitis is more of an orthopedic mechanical issue. Now, diabetics can get plantar fasciitis. I've had it myself. Often we'll find it's an irritation in the ligament on the bottom of the foot. Often good shoes and stretching can help it directly. And if you're diabetic, sometimes it's hard to tell, is that heel pain coming from plantar fasciitis, or is that my neuropathy pain or how I walk? So sometimes getting that checked out to see, hey, how much of that pain is actually coming from the heel? But there's many things that can be used to treat it.
Okay, another question. I've noticed that within hours of eating, my feet swell when I eat foods high in sodium. I'm always cutting back on sodium, but it seems to happen every time. I'm not completely sure the sodium is the problem. What's the best thing to do in this case?
In that case, it may be worth making a log, even weighing yourself every day. And that's something when you go to see either your medical doctor, family practice, your nurse practitioner, or your cardiologist, to show them, hey, my weight really fluctuates. Because a lot of times if you're gaining weight in your legs, it often adds weight to your body. We sometimes find that people that have high sodium diets, where salt goes, water follows, but actually in the middle of summer with the humid, people will get swelling in their legs, or if they sit with their legs down a lot, they may have weak veins. And so with letting your legs hang, they get more swollen. I never tell anybody to cut out salt all the way, because there's some people that are just the opposite. They have low salt. So I think it's a great question, and I would definitely take that to your medical doctor at your next visit. You may find by keeping your body weight and measuring it every day, you can show your doctor how much it fluctuates. Also, you may notice or go over your medication list with your doctor, because sometimes medications can help control swelling. They can also help sometimes with the side effect cause swelling. So the salty diet is definitely a good suspicion, but I would also raise that information to your doctor, see if there's any other underlying problems.
Okay, we have another question. Is it okay to wear socks and shoes, like closed-toed shoes, every day?
Absolutely. I just think, sometimes we get a little lazy, especially with COVID, we may not change them. I think changing your socks, checking your feet every day, especially during these hot summer months, are really important. Socks provide a bilayer between your skin and your shoes. If you think about it, hey, it's hard to wash your shoes, but that sock is something you can launder. You may find if you have them on for a couple hours, your feet get a little sweaty. So even using a foot powder inside your shoe to control your moisture, I usually encourage you to put it to your skin, not just put in your shoe. Otherwise you might get a cake powder buildup in your shoes. And then maybe other times during the day, switching over at the end of the day or in the morning to a sandal so your foot can get a little air. I often encourage you to alternate that. Now, some people wear a special work shoe so they can't, and then just changing your socks. I think that's better than going just with your shoes on with no socks if you have a closed-toed shoe.
Okay, another footwear question. How do I receive diabetic shoes? Do I need to go through my doctor to get a prescription for that?
It's a great question. Unfortunately, these days, sometimes the insurance makes more of the decisions than we do. But what I can tell you is, under Medicare, people that have Medicare can qualify for diabetic shoes. Now, not everybody qualifies. You have to have risk factors. It may be you have circulation problems or neuropathy, and I don't think it's hard to qualify. You may have a hammer toe or something with a history of a sore that you should get a pair of diabetic shoes. Often with your medical doctor, they can give you a prescription and you can go and get evaluated. We actually at our department don't provide diabetic shoes, but we do send people out to get diabetic shoes. And it's something your doctor can often give you a prescription for. Sometimes, as we started this answer to this question, I say checking with your insurance provider to see, because some people have Medicare replacements or other insurances, to see if there's any special rules that help you be able to get those diabetic shoes.
Okay, thanks. Another question. Could I have an X-ray done to tell if I'm developing diabetic foot complications like Charcot foot?
So X-rays always help, but also your past medical history or what's going on. Probably the best thing to do is meet with the doctor or the medical provider and tell them what's going on, and they can determine if you need an X-ray. Often it's a good thing to do, especially if you're having a bone problem, a tendon problem. We often will look at foot structure, the alignment. We can see if there's a fracture or any other problems hiding underneath.
Okay, another question. Do you provide regular It says pediatric, but I think it means podiatry care to UF patients.
We at the Orthopedic Center see all patients. Often I'll ask you to ask your medical doctor for a referral. Some of the goals at the Orthopedic Center is more related from ankle and foot or shark or wound issues, but we see all patients. So the best thing I'd say is talk to your medical doctor about what's appropriate for you. We have some people that are diabetic that have no risk factors, so they actually take care of their feet themselves. Other people have very high risk factors, and we make sure they get taken care of.
Okay, I don't see any more questions. I'm going to just wrap it up, but if you have another question, let me know. I'd like to thank you guys for attending today, and thank you so much, Dr. Neville, for taking time out of your very busy schedule. And I really appreciate everyone participating today. As I said, when you leave this, there's a survey that's going to pop up. If you want to give any feedback to Dr. Neville or myself, or ask us any questions, we'd love to hear from you. So thank you so much for tuning in today, and I really appreciate it. Have a great day.